Right, so just where we left things is with this paper by Rocco et al. And they explicitly recognize that while social capital may affect health, health may affect social capital. And so here we're moving away from a single equation approach and having two equations, or sometimes described as a simultaneous equation model. And so in the first equation, the health measure is self-reported health, and it's being regressed on a measure of individual social capital and a measure of community social capital. Recalling, if we go back, yes, it's this one here. There's various ways you could measure, or they measured, community social capital. Their measure was the average of the individual level of trust, but the average across different groups of individuals. Individuals defined by age group. Right, so those are the different ones. So these are simply different measures of community social capital. And then they're finding themselves in the equation here at this point. The Z and the X are, again, a series of control variables. And so that's the first equation. Health depends on social capital, that's individual social capital, and on community social capital, and then on a whole lot of control variables. In the second equation, it's explicitly modeling individual social capital as a function of self-reported health, community social capital, and these control variables. Now, I won't go into the statistical econometric complexities of it. They don't really matter for our purposes. But the key point is this: if you do believe that social capital is to some extent a function of health, if you just estimated equation 1, you're going to get the wrong answer, as it were, as to what effect social capital has on health. If you don't allow for the relationship possibly going in the other direction, if you don't allow for the idea that social capital and self-reported health are, as it were, created together, they're determined simultaneously. So what this author's trying to do is to say, well, a lot of studies have just regressed health on social capital. I'm going to, while doing that, I'm going to regress social capital on health in the same simultaneous model, and thus allowing for that relationship that was emphasized in the earlier paper by flashback. Yep, there we are, Scheffler, and he was arguing, yes, there's an important relationship from social capital to health through these mechanisms, but there's likely then to be a move back from health into the social capital. And so this paper I'm now finishing with by Rocco is explicitly trying to test that. So let's see what they found. Right, this time I've made it look a bit more like a regression. I've actually put numbers in. Before I was just, putting in positive, significant, negative, significant. All these are to some extent significant. The level of statistical significance is of course arbitrary, but in this example, 3 stars is a significance level of 0.01, 2 stars for the 5%, and this is, well, significant at 10%, but you might argue that's not really significant. 10% is a little bit high. So what have they found? Well, so we've got 2 equations. One equation determining individual social capital, another equation determining the self-reported health. If we look first of all, individual social capital, what they found was that there was quite a strong negative relationship between the individual's social capital, how much they trusted people, and whether they'd been a victim of burglary or assault in the last 5 years. Now that's not perhaps too surprising. If you've been a victim of burglary or assault, you are possibly less likely to trust people. So that could be taken as, it's not positive, but it's positive in the research sense, that it's perhaps suggesting, it could be interpreted as some suggestion of validity, that your measure of social capital, it's behaving as it should, it's related to that variable. And importantly, what they found was that the individual's self-reported health has a strong positive relationship with the individual's social capital. So in other words, individuals who report high degrees of trust also reported high health status. And then finally, they found a positive relationship between the community social capital and individual social capital. Remember, the individual social capital is the extent to which you trust others. The community social capital was a sort of reference group, peer group, average level of individual trust, and found a strong positive relationship. So that's one equation. The second equation determines health, and health is partly determined here by the number of doctors. Good news for doctors, although we spend a lot of time saying there's a lot more than healthcare to impact health, but number of doctors in the region in which the person resided has a strong positive relationship with self-reported health. Community social capital has a positive relationship, maybe not statistically very strong, with self-reported health. And individual social capital has a strong positive relationship. So what this is showing is this circular relationship between social capital, or these results are showing, between social capital and health. So this study is very interesting in that it's documenting this phenomenon that I've been alluding to throughout the lecture, that maybe we can't just focus on the effect of social capital on health. We have to take into account the sort of feedback loop. This study shows that community social capital, as defined here, the average of individual levels of trust among your reference group, community social capital has a positive influence on both individual social capital and on health. And the final point I'd make here is that the beneficial impact of social capital on health is at least an order of magnitude greater than that of community social capital on health. So if we're looking at social capital's influence on health, and looking at the size of these coefficients, the individual social capital is at least 10 times, but rather more probably, stronger effect than the community social capital. Now, of course, that might be relevant for policy purposes in that it becomes more important possibly to work on somebody's individual social capital and not quite so important maybe for community social capital. So that's quite an interesting study, and that was the one I wanted to finish with. And so, just to summarise, how I would characterise social capital in health economics is as follows. As I've said, I think health economists joined in this research area a bit later than many other researchers. But having joined in, I think we can characterise the contribution of health economics or health economists in this area as partly being increased or greater emphasis on theory, partly also a greater interest in causation rather than association, and certainly health economists have been very keen, if they observe an association, not to claim any more, just to say they're associated. They've not without additional evidence would they ever say the relationship is causal. I think there's been progress, but I'd also have to say it's not particularly rapid. You know, we're learning. Each year there's a few more papers. I think a feature of the health economics work, and it's probably true of a lot of work on social capital by other disciplines, is there's a reliance on existing data. So it may be data that was really collected for another purpose. And then you're using that to try and demonstrate the relationships. And so that's to some extent a little bit of a weakness if you're sort of looking around for something you've got data on and then saying that might be an indicator of social capital, I will use it. Rather than starting with what is social capital, ideally how could I measure it? Okay? Is there any questions about this part? Yes?
Back to my last slides.
Mm-hmm.
There's individual, social capital. Yeah.
This one? Or do you want the numbers or the equation?
This one.
Yeah.
Individual social capital and the community social capital. The community social capital using the footprints index to measure.
Mm-hmm. No, individual social capital in this paper by Rocco is how people responded to the question about trust. Most people can be trusted, or maybe most people really can't be trusted. And so it was a 0 to 10 scale. I think I might have that. Oops, going the wrong way again. Excuse me. Yeah, here we are. Generally speaking, would you say that most people can be trusted, or that you can't be too careful in dealing with people?
Or use only one question to...
One question. And then that answer is sort of being recycled as community social capital, but to get that, you're not averaging across the individual response across everybody, you're averaging it across a reference group, a sort of more limited age group.
So the reference group is the community social capital?
That's right. The average for the reference group is the community social capital in this study.
In this paper.
Yeah.
You said it's more important to to look for the causation rather than association.
Well, obviously we're interested in association because if there's no association, there can't be any causation. But ultimately, I think we're interested in causation because if something causes something else, by impacting, if our policy can impact on the something, we can then obtain the effects on other things.
And one measure is to find some instrumental variable to find the causation.
One approach for testing for causality is instrumental variables, yes.
And is there any effective instrumental variables?
Well, I don't overgeneralize, but instrumental variables, they're a great idea, but we have great deal difficulty finding such variables. Again, part of the problem comes, we are typically using existing data sets, and the existing data sets have been designed for various reasons. They haven't usually been designed with testing, causation, and causality around about social capital in mind. So they're collecting the data for different reasons. If you recall, you might not, on Friday afternoon I showed you what data was now being routinely collected in England and being called social capital. And it was a set of responses from different surveys. So there's a crime survey that's annual that takes place each year and asks a random selection of people about their perception and experience of crime. And that's going on, and it's going to be done anyway because policymakers are interested in or the level of crime, because a survey will capture some that's unreported, things like that. So it's going to happen anyway. But then the statisticians or the statistical agency are taking some of the responses from that crime survey and turning them into social capital measures and things like that. There's a European social survey where simultaneously in a number of countries each year or every few years a whole series of questions are being asked. Now this is because people are interested in comparing countries within Europe. And again, the statisticians from the statistical agency are saying, oh, we could use some of those as part of our measure of social capital. And so it's that problem that typically you're not starting with a blank sheet and saying, right, what would I really like to measure, and then going out and collecting it. What you're doing, and we all do this in our research to some extent, what you're doing is thinking, what data are available? Can I use it? And I think it's that issue which is causing us to not make as much progress as we might. But of course it's much cheaper. I mean, it's a lower cost activity to use data that's been collected for some other purpose. Yes?
Could you go back to the table which is showing?
Yeah. This one.
Yes.
Yeah.
When looking at this table, is it fair to say that individual social capital is a stronger predictor of someone's subjective health compared to rather than community social capital?
I think it is to say it's having, quantitatively, it's having much more effect. So variations in individual social capital are having a much bigger effect. Also, statistically, there's a big confidence interval around this, whereas this is a tighter estimate. Standard error of the estimate's much smaller. So in that sense, it's fair enough to say that. However, I guess if we think about implications for policy, which I'll be coming on to a bit more now, if you change community social capital, that's changed for everybody, potentially. And so, although the individual effect is small, you might be having that effect across a lot of people. If you change an individual's social capital, or a group of individuals' social capital, it's having a big effect for them, but not so much impact on other people. So I guess what we can't really say is, from a policy perspective yet, this is not enough information by itself to say which is more important. Also, I do come back to the idea that community social capital here is being argued to simply be a function of individual capital. It's not an average of all individuals, but an average of the reference group. Now, again, I come back to the idea that I think maybe there's something about community social capital which is more than just the sum of the individuals. And this is saying really it's just the individuals. Right, okay. Now I don't know if this travels culturally. This was a picture I took in Croatia, which is of course in Europe. And it's not just Croatians that do this. I was going to say young couples. It probably is largely young couples. But maybe old couples do it as well. I think that the padlock is signifying the lasting relationship, or the aspiration, or the pretense if you're cynical. So the aspiration, it's a lasting relationship. And I just like this one. This was just walking along the road, and then there was this fence. And this was just a small part of the sea of padlocks. So this is social capital again, perhaps. Bonding social capital. That's what it meant to me. Again, I wasn't psychic. I didn't know that at the time, that I would be talking about it. But yeah, so the question is, a simple policy question is, should we be encouraging more of these? Now, I don't mean should we subsidise the cost of padlocks, but should we be trying to encourage more relationships? Or other things that might encourage the development and sustaining of social capital. Do you do this in Taiwan? I don't mean you personally. Do people do it in
But I find this quite, you will see many in Japanese and Korea countries, but not so much in Taiwan.
Right. Kenya? No.
But there are other forms, like if they have some beads or...
Yes. Okay. That's right. And it has become, I have noticed, people wearing, it's become more global, wearing sort of friendship bands or whatever they're called. And of course, I'm thinking more traditionally, and this is very unecological, people used to carve initials on trees and things like that. Well, it's all social capital. It doesn't do the tree much good, but maybe it's good for health. Well, that's the question, is it good for health? Okay, so lecture 4. I'm going to try and get implications for health policy and maybe for research. And I add the and research because I think the implications for health policy are not obvious, and that's probably because we need more research. But let's see about that. So, should health policy care about social capital or not? I mean, we worry about how many doctors or nurses we've got available. We worry about patients' access to health care. We worry about whether prices are too much of a barrier to accessing health care. We worry from a more public health perspective. We worry about disease prevention and health promotion. We worry about clean water and sanitation. We worry about improving diets. Should we add to our worries and worry or be concerned about social capital? Should we be doing something or a series of things about social capital? Now, maybe we are already. I gave the example earlier today about social norms, and my example, which I felt was a very strong one with respect to social norms, was the changing attitude towards smoking in public. Okay, so that's the issue. Now, potentially, there may be important distributional implications and we haven't touched on this yet, and I want to look at it now. For example, there may be a relationship between social capital and socio-economic inequalities in health. Now, the sort of thing we're going to look at is, to what extent, if we have more social capital, is that going to improve access to health care, perhaps reduce inequalities in health? Or might it be that increasing social capital, like so many programs that improve health or opportunities for health care, is going to increase inequality because the group that gets the greatest gain are those who are already advantaged? So we'll look at that. I think it's quite reasonable to believe, so that's one reason you might be interested in, for health policy purposes, interested in social capital, the distribution aspect. I think the second one, and it's a fairly obvious one, is it's quite plausible that the effectiveness and possibly the cost effectiveness of different health policies may depend on the extent and nature of social capital. Some health policies may not be very effective if you don't have enough social capital, for example. So that's seeing social capital very much as an input, that along with all the hospitals and the health services and the healthcare personnel, you maybe also need social capital to get the greatest health benefits from those investments. Maybe mental health and social care are really good examples of this, where it's not just enough to look at the inputs, traditional inputs to healthcare, such as doctors, nurses, drugs, etc. You maybe have to look at other inputs to healthcare, in particular the social capital. Now, it might also be that policies which are aimed at increasing social capital or sustaining levels of social capital, they may be a cost-effective way of securing better health outcomes. The example here, if we go back to it, smoking. Quite possibly changing the social norm regarding smoking in public is a much more cost-effective way to obtain improved health than supplying individual counselling to smokers, or nicotine patches to smokers, or things like that. And so that's a possibility we need to bear in mind. So, what about the first part here? So, see, there is some structure to these lectures, believe me. Well, there's meant to be a lot, but I'm going to do each of these three things. We start with the first one. First off, we're going to look at possible distributional implications. So there's quite an interesting paper just a few years ago, Uphoff and colleagues, published in the International Journal for Equity in Healthcare. And what they did was a systematic literature review. And what they wanted to know is anything known about the relationship between social capital and inequalities in healthcare, socio-economic inequalities. So they did a systematic literature review, identified 60 studies, which, I don't know, doesn't seem very many, but that was 60 studies. Their strategy essentially was the studies had to be, one, about social capital, and two, must say something about socioeconomic inequalities in health. But anyway, they identified 60. And they found 56 of these studies confirmed a positive correlation between social capital, health, and social inequality. So 60 studies had to some extent gone out and looked for what sort of relationship there might be between health, social capital, and socioeconomic inequalities in health. 56 of them found some, or found a positive correlation. That's interesting. However, only 19 of these studies formally tested for interaction effects between social capital and social inequalities in health. In other words, to what extent is the relationship between social capital and health influenced by socio-economic inequality? And they structure their discussion of these 19 papers with respect to 3 different hypotheses. A buffer hypothesis, I'll explain them each in turn, dependency hypothesis, and a contextual hypothesis. So let's start with the buffer hypothesis. To quote from them, components of social capital can provide a buffer. No matter how good your English is, buffer might seem a little bit esoteric. A buffer, a sort of protective barrier. Trains, I don't know if they still do, used to have a buffer at the front, and so if they hit something, the buffer absorbed the impact. That's the word buffer here. So components of social capital can provide a buffer against stress and other negative influences on health and well-being in tightly knit communities. And so what they're thinking of here is, if you imagine social capital being measured along the horizontal and health on the vertical, what they're suggesting is possibly there really isn't very much relationship between social capital and health if you belong to a high socioeconomic status group. So if you are an advantaged, socioeconomic advantaged individual, the relationship between social capital and health may be virtually non-existent. On the other hand, if you belong to a lower socioeconomic status group, it may well be that there's a positive relationship between health and social capital. Because this group benefit from the buffer effect of social capital, the protection that social capital offers. The high socioeconomic group don't need it, don't need the buffer. So that's one hypothesis. Of 18 studies that examined the relationship between social capital and health by socioeconomic status, 11 found evidence to support the buffer hypothesis. So some support there. I've got an example here. Van der Wel, judging by the name, one would imagine it would be a Dutch study, but being published in Norsk Epidemiology and being a study about the residents of Oslo, it's a Norwegian study. So they had data on almost 12,000 residents of Oslo. They had measures of social capital for 25 different administrative districts in which these 12,000 lived. So social capital was estimated from the responses residents made to a generalised trust question. So similar to the study we've just been looking at. The generalised trust question is, how much do you trust other people? A lot or little. And the measure of social capital here is an average of those individual responses. So it's the responses of people in the administrative district you're in. So Oslo is divided into 25 administrative districts, and to get the measure of social capital, you're taking the average individual level of trust in each of the 25 districts. They also had a question about participation in voluntary organisations. And what they found was in the communities or administrative districts with high levels of social capital, there was a positive impact on the self-rated health of those with the lowest income, and no effect on self-rated health for those with the higher income. So that is directly speaking to what we're just looking at here. Those with the higher income, there was no impact of social capital on health. those with the lower income, there was a positive relationship between these measures of social capital and health. And indeed, about 11 studies came up with support for that. This just being one example. Okay. You've got that post-lunch thing. You know, it was only 3 of us went to the Italian. The rest of you probably starved by contrast with us. I need a trolley to wheel in some caffeine for you. Right. That was the buffer hypothesis. What about dependency hypothesis? Dependency hypothesis. Again, the quote's directly, well, from the original survey paper. People with a low socioeconomic status will generally have less capital, and the amount of capital available to them cannot be used as effectively for the benefit of health. So this is back to the idea that we do see with respect to some public health programs, the groups that benefit most, in a way paradoxically, are the more advantaged groups to start with. Classic example of this is introducing screening as an option. And the groups that have high participation rates typically are the advantaged groups. The groups with the lowest participation rates in the screening program are the disadvantaged groups. Anyway, so the idea being here that in order to get the benefit of social capital in terms of improved health, you have to belong to the high socioeconomic status group. If you belong to the low socioeconomic status group, you might get some benefit. The line is positive slope, but not very much compared to the high socioeconomic group, socioeconomic status group. So they found 8 studies which looked at this that didn't find any support for it, for the hypothesis, but they did identify 3 studies that argued there was a dependency between socioeconomic, between social capital and socioeconomic inequalities. So the majority were not finding support for this relationship. Got an example here. Study that I think did find support. Which way around was it? Yeah, so it's a large US study. Now, the fact it's got 30,000 respondents, you immediately know it wasn't a study about social capital. You know, these data are being collected for something else, and then somebody's repurposing the data for this purpose. And so it's this study by Gorman, and in this large US survey, they found that the probability of hypertension, so that's, if you like, a measure of ill health, the probability of hypertension decreased with higher levels of social integration for all groups who had finished high school. So they are finding a relationship between social capital and the health measure, so long as people belonged to the more advantaged group. They belonged to those who'd finished high school. Social integration was measured by the number of specific activities they'd engaged in the last 2 weeks, such as talking to family or friends on the phone, attending a place of worship. Are sort of usual suspects: relationships with the family, religious participation. Okay. So just to summarise, dependency, there's not much evidence for the dependency hypothesis, but I've just shown you an example where there was some support. And the third hypothesis about the interrelationship between social capital, health and inequalities is called the contextual hypothesis. Social capital might benefit the better off in society, while excluding people with a lower socioeconomic status or minority position. So this is even more extreme. This is an idea of social capital being good for some people, but actually more social capital worsens things for others. And it's because of perhaps the nature of the social capital is it tends to exclude others, and in that sense make their relative position even worse. That's the sort of thinking. And so here we've got it represented graphically. For the high socio-economic status groups, strongish positive relationship between increasing social capital, increasing health. But for the low disadvantaged groups, as social capital increases, the very thing that's helping these other people, as it increases, they're getting worse off. And maybe reassuringly, they found very limited evidence to support this hypothesis. Very limited. There was this study, another large sample, again, another survey done for another purpose, of 21,000 residents. And a subgroup analysis showed an interaction with individual trust for self-reported health. So, the self-reported health was this. How would you describe your overall state of health these days? For people who reported a high level of trust, the community level trust, so that's the sort of aggregate of individual trust, the community level trust was protective of their health. So if you report a high level of trust yourself, and you're in a community where there's a high level of trust, that seems to benefit your health, a positive relationship. Whereas those people reporting a low trust score, so they themselves didn't trust others, in that situation, if there was high community trust, then that negatively affected their health. So it's an example of this sort of divergence. It is support for this contextual hypothesis. But I do stress there was really very limited support they found for this, but this was an example. Now, if you go looking for these things, you might find them. And if you've got a big enough sample size and different ways of selecting your subgroups, you increase your chances of finding something like this. So I'm not saying this doesn't exist or it's just an artifact. I'm just saying before I put much faith in the contextual hypothesis, I'd probably want to see more studies to convince me. So to summarize, we had our three hypotheses, buffer, dependency and contextual. The buffer hypothesis had the greatest support. The dependency hypothesis was a bit of support, but most studies didn't. And this one had the least support. So, in answer to should we worry about social capital from a health policy perspective because of the potential effects on inequality, the answer is, well, that might be a reason. It might be one of the reasons to pay attention to social capital. Okay, moving on. Mental health and social care. Martin Knapp, the K is silent, by chance another health economist I know reasonably well. He's based at London School of Economics, which is about 1 kilometre south of London School of Hygiene and Tropical Medicine, where I'm based. He argues that social capital may be particularly important with respect to mental health and social care. Because if we take mental health, it's true that most mental health illnesses are chronic conditions. Obviously some are not, but most are. Whatever we do know about them, they are a complex combination of many factors, biological, environmental, social causes. We certainly also know that there's significant stigma and discrimination with respect to patients suffering mental health difficulties. And so he would argue that mental health, in particular, the role played by, potentially played by social capital, might be a really important one. Rather more important than perhaps some other patient groups that don't have these, quite such a complex etiology, don't have so much stigma and discrimination. And with respect to social care, he emphasises that in virtually all countries, informal carers, unpaid carers, play a major or the major role in providing social care. And he would argue that a lot of these individuals are helped continue in their role as unpaid carers if there's more social capital. If there's less social capital, they themselves then find it difficult to continue in the role of unpaid carers. And so he would argue that while health policy generally maybe should be interested in social capital, people making decisions in the context of mental health and social care should particularly be sensitive to the potential role of social capital. Now, the last bit I want to sort of touch on is this. It's the potential contribution of social capital to the value of healthcare, and that social capital may bring a lot of benefits in terms of our valuation of healthcare. Now, we have a tendency, health economists have a tendency to focus on health technologies, and to what extent do health technologies help us improve or maintain health. Not just drugs, but a huge amount of the effort goes into evaluating new drug therapies and what is their potential contribution to improving health. And we do that, I think, partly because things are relatively measurable when we're talking about new drugs. If we're talking about new drugs, in order to get permission from regulators, there's typically randomized trial data. And a randomized controlled trial gives you a very good prospect, not a guarantee, but a very good prospect of measuring treatment effect, identifying what is the impact of this drug compared to some other therapy on the patient's health. It's back to being measurable. It's highly measurable, and I think that's partly why it attracts so much interest. Of course, the other reason, perhaps a more obvious one, is there's a huge industry out there coming up with new drugs, and it's a massive industry. And naturally enough, health economists are quite attracted towards the opportunities that brings. Now, there are many, as I'll be talking on Wednesday, I'll be talking about this issue of using economic evaluation to assess the cost effectiveness of new drugs. And as will become clear, I hope, on Wednesday, it's not easy. It's still really very difficult. You've got much better opportunities with respect to data, evidence, and so on, but it's still very difficult. But what's clear is it's much more feasible to assess the potential contribution to health of a new drug than it is with most health policies. Most health policies are difficult to evaluate. They're difficult to evaluate partly because trialling the policy is not usually an option. It's pretty rare where we can randomize different people or different locations to a different health policy. There was a very famous experiment done called the RAND health insurance experiment done in the United States back in the 1970s, where they did randomize quite a large number of individuals to different insurance plans. And because it was done as an experiment, the belief was you were going to get a better estimate of the impact of different insurance policies or schemes. But that's pretty unusual. We don't usually have that opportunity. And I think social capital is a bit like that. It's really quite difficult, for example, to imagine some sort of randomization process. Now, you sometimes may get what's sometimes called a natural experiment, where almost as an unintended consequence, you've got one group or one location exposed to a particular policy and another not. What we sometimes find is when we're introducing a policy, it's quite difficult to introduce it everywhere at once. And so there's always some locations which may be leading ahead of others. There's always some that are further behind. Now that does give some opportunity. It's got its own problems as well, but it does give some opportunity to identify, if you like, the treatment effect of the health policy. What is quite interesting about health technology assessment, and particularly evaluation of new drugs, is you almost forget about the health service. All you're focused on is, if we introduce this new drug, what will the effect be on patients' health? What will the effect be on the change in resource use? We barely stop to consider what else we need for the drug to work. And what else we need is a well-functioning health service. Now, in countries like England, and in countries like Japan, and in countries like parts of the population in the US, they have well-functioning health service. And so you don't have to worry about are there enough doctors and nurses in order to implement the change of treatment strategy. But in lots of other countries, that's not the case. You've got a missing input. You're not just combining doctors, nurses, radiologists, pharmacists, drugs, beds together, but you've actually got a whole infrastructure that you're assuming is present for things to work. Another way of saying this might be, we're assuming there's adequate social capital. And so, if there is, the health policy may well work quite well. If there's not, it may work much less well. And that bit is missing whenever we are evaluating new drugs. Or at least, if we're doing it in a country like the United States or Japan or England, it's missing. What is that contribution of social capital to producing the health benefits? Now, suppose we did want to evaluate policies to increase social capital. Well, first of all, intrinsically, this is going to be very hard to evaluate. Think of all the problems we've had measuring it, or agreeing what is social capital. So it's going to be really quite difficult to evaluate the effect of increasing social capital. In economic jargon, which I have tried to avoid most of the time, our problem is this. We've got a very poor understanding of the production function. We've got a poor understanding of what we have to combine together, what inputs, in order to produce our output, our change in health. Now, we also have rather poor understanding of the production function for social capital. What do we have to combine together to increase the level of social capital? So those are two major problems. Suppose we want to evaluate changes in social capital and the impact on health. We need to know what it takes to change social capital. Now that has received rather little attention. A lot of the effort has gone into sort of measuring social capital, measuring health and saying, oh, they're associated. But how do we produce social capital? And then the second one, as we increase social capital, what additional outputs are produced? What are the changes in health that are produced? And it's that information, the understanding the production function, without that, it becomes so difficult to evaluate policies to increase social capital. One of the problems, I think, is the pervasiveness of social capital. It's everywhere around. So it's quite hard to identify discrete additions to social capital. Now, if we compare that to introducing a new drug therapy, we'll have data on existing treatments, we introduce a new drug, and we can collect data on how things change. It's a discrete change. With social capital, adding to what's there, we don't actually have very good data of what's there. So it's really quite hard to identify the increment. As I think, emphasised last couple of days, well, last week and today, social capital potentially takes many forms. If we go back to literature on it, there's emphasis on networks, there's emphasis on relationships, there's emphasis on social norms, there's emphasis on participation in group activities. It's also probably a problem of multiple outputs. Social capital doesn't just affect health. It's going to affect other things. What about education? Now, I haven't gone down this line at all, but let's forget health and think about education. Is it easier to learn where there's more social capital than less? Well, one imagines it's much easier to engage in education and to positively add to your knowledge and skills in an environment where there's lots of social capital rather than less social capital. And then, of course, a fundamental problem, excuse me, is the problem of attribution. If we do see a change in health and we've changed social capital, can we attribute it to the change in social capital? So we're back to our causation. It might be because of the change in social capital, it might not be. Some of it might be due to change in social capital, but not all of it. So there's a raft of challenges that make it really difficult to evaluate policies to increase social capital. Question, yes, comment.
I have a question about the social capital takes many forms. Do they differentiate between creating a new social capital and maintaining an existing social capital? Or it doesn't matter as long as it's there?
Well, I think we don't know. I don't think we know the answer. I think part of the literature, the attitude is, as long as the social capital's there, maybe it doesn't sort of matter where it came from or what. And maintaining social capital may be just as valuable or more valuable, who knows, than adding social capital or having to introduce new social capital. It's a good question. I don't think we know the answers. But again, it's important from a policy perspective because you'd be engaging in a different set of policies. I guess I might comment that policymakers quite like doing new things. It doesn't sound very exciting to be doing a whole lot of activities that maintain the position. It may be very worthwhile, but it's not as seemingly not as attractive as bringing in new initiatives. But it may well be the case, it'd be a very interesting study, I don't know how I would do it, but it'd be a very interesting study to compare the cost effectiveness of maintaining existing levels of social capital as compared to allowing them to sort of deteriorate and then building new capital.
Because I'm thinking about people, for example, aging people, elderly people, they are more likely to maintain the old existing social capital, keeping the social relationship with friends and survive relatives instead of creating a new social capital. So I think we should look into maintaining as much as creating a new social capital.
Yeah. Well, as I say, I think that's a perfectly reasonable view. I don't think we've any evidence, but you could write whole PhDs on this. Wrong audience, because you're already, most of you, writing one on something. But yeah, it's an important question. I don't think we have a clue really as the answer of it just now. To a large extent, we're at an early stage in just beginning to try and understand what works, what makes social capital. I don't think we've got anywhere near being able to answer the question, if you did want to answer it or ask it, what's the most cost-effective way of maintaining or sustaining social capital? But well, maybe the next generation of researchers are going to tackle that one. Soon, I hope, before all the existing social capital disappears. I think governments can assist in the development of social capital. It'd be strange if they couldn't. Scheffler and Brown, the authors of the paper I was introduced today at the start, suggests providing funding or fiscal encouragement, that's a tax break or that sort of thing, so that it's easier to build social capital. Yes, there's lots of evidence that if you tax people, tax an activity, you'll get less of it. If you subsidise an activity or reduce the taxes, you'll get more of the activity. So I think Scheffler and Brown are on safe territory saying this. Unfortunately, they don't go beyond this level of generality. I guess there are existing policies in some countries where they reward the very wealthy for being generous philanthropists by reducing their tax bill. So there's existing examples of that sort of behaviour by governments. Second thing that Scheffler and Brown identify, and I quote them directly, what governments could do is to generate enthusiasm among communities and their leaders to generate social capital. Now, I have to say I find this a vacuous statement. Politicians are probably the worst people to look to generate enthusiasm among communities. These days, there's such a high level of distrust. Maybe the politicians could add to social capital hugely by becoming more trustworthy. But I don't know. But I might get the point that if you can get local communities to be much more enthusiastic about things and believe in the value of these activities, then you would hope to get more of these activities. I just don't quite see how governments can encourage this, but I'd be interested in your views. What makes things happen more I don't know, in a local context, you could build more halls that are open access. Any group who wants to can book time in the hall for a nominal fee or something like that. Maybe that would generate social capital. It would improve your measure of social capital because you could probably then have more organisations, more meetings, higher participation. But one hopes it might do more than that. Maybe there's loads of things here. Creating more public spaces. If we think of the direction we've gone in terms of urban development, we're using up spaces. building more rather than creating more public spaces. Or we've got public spaces where people no longer feel safe. We need to reclaim them so that people have confidence to be in them again. So maybe these are things. It's not that there aren't things we can do. I think it's knowing which ones to choose. Because the nature of almost any policy or attempt to increase social capital is it's going to require resources. Resources that are having to come from somewhere else. So you're having to give up something else somewhere else, give up some benefits somewhere else to get these benefits. But the problem is, if the decision maker then says, well, show me the benefits that investing in this social capital will produce, it can be quite difficult to come up with the evidence. Doesn't mean it doesn't exist, that the benefits don't exist, but it can be difficult to come up with the evidence. And that was actually my last slide, because I want to hear more from you guys. This literally is what health economists have said. Most of them have been silent about policy. Yeah, please.
I have a question.
Please.
Is there any kind of attempts to evaluate the social capital and its relation to health qualitatively, like interviewing or depending on qualitative data? Or is it always about measuring by numbers?
In the health economics literature, it's certainly measuring by numbers, it's quantitative. The political and sociological literature is not unquantitative, but it's less quantitative. But almost the whole thrust of social capital has been this sort of measuring something and then showing it going up and something else going up. You certainly, everything is susceptible to qualitative investigation, and probably there's quite a lot that can be learned. But the papers that are produced tend to be focusing on the numbers.
I know, because even in public health, it's usually like this. It's more trusted if you can see numbers. But no one can deny the importance of qualitative assessment, because sometimes you can find things that are not shown.
I wouldn't disagree with you. I'm agreeing with both statements. Sometimes you can find things out that you wouldn't find otherwise. And the statement you had just before it, that if you don't have the numbers, it's very hard to persuade people you've got evidence.
Yeah, they complete each other.
I think they do complement each other, yes. Yeah, I agree. The literature I'm most knowledgeable about is quantitative. I'm not saying there isn't qualitative work there, but, and clearly, a lot of the qualitative does feed in. I mean, if you're going to think, what on earth should I measure? You need to talk to people as to what they may believe or not believe does influence their level of trust, for example, things like that. So, yes, I think you've got to do the qualitative work, but I think maybe it's easier to publish research that's quantitative. I mean, that's a very cynical view, but maybe it is. Mm-hmm.
In the UK, is there any real example to evaluate the policies to increase social capital?
I think the answer to that is
in the UK
yes.
or in London?
I think there's increased interest in evaluating policies that build or sustain social capital, but there's not a lot of understanding as to how to do it. So, for example, I know that in London itself, which is a big city of about 8 million, the local government are increasingly interested in how sort of urban space environment, transportation, and all sorts of factors come together to produce more healthy cities.
Yeah, yeah.
And so they are getting more interested in that, but there isn't a sort of recipe book or a sort of toolbox or a sort of plan that says, right, if you're interested in this, you need to do this. So the stage I think we've reached, particularly in London, is there's a willingness to see that things are much more interrelated, but they're not quite, I think it would be fair to say they're not quite sure how to operationalise that and move it forward. So for example, there's quite a lot of interest in recent years in air pollution, and in the last year or two particularly worrying about exhaust from diesel engines. Up until a few years ago, UK policy was to encourage diesel engines because they thought that it was somehow less damaging to the environment than petrol engines. It's not, it's more damaging, and so now they are grappling with what can we do to tackle this, and what set of policies to adopt. And so I think it's not that there's not a will to move, or say move forward, that's a value judgment. It's not, there is a will, there's just, people are unsure about how to collect appropriate evidence, how to design appropriate policies.
I had asked my question because the UK has developed such a method in the London Olympics in 2012 because they did a lot of development in East London to hold the Olympic Games. So I thought the UK government or London government has done something to
They have funded some research. Some of my colleagues I'm in the Faculty of Public Health and Policy. Some of my colleagues have research projects arising directly out of the London Olympics, and they're interested in the sort of legacy. Now originally the legacy they're more concerned about was a sort of sporting legacy, that you know, the demonstration effect of the Olympics and the excitement might encourage young children to become more active and take up sport and continue doing it. Increasingly, they're also thinking about the legacy in terms of holding the Olympics is not just an event, but you're changing the infrastructure in a part of London that was relatively low income part of London. And what are the benefits of improving transportation, improving job opportunities, building more houses and things like that, creating new green spaces. So that is actively being researched.
And the whole development has increased on social capital in London.
The Olympics, you mean? Or I guess it... I think there was some initial evidence of increased participation in sport. Now, whether that was down to holding the Olympics or so happened, unusually enough, the British team did quite well, you know, across the board in all sorts of different sports. And whether that was the sort of the catalyst, I don't know. As far as I can make out, that aspect of increasing interest in exercise and exercise levels and participation seems to have faded a bit. Seems to be a bit short-lived. What we perhaps wait to see is whether the infrastructure changes have longer term effects. Of course, Tokyo is hosting Olympics in 2020. 2020. So maybe there's a research opportunity there. Although, is the approach to take existing facilities and reuse them, or is there going to be a big redevelopment going on? Does anyone know?
Like there could be like some side, like in the side of the forest, so like it could make it easier for like a foreign living in Japan.
All right. So the social capital of foreign people living in Japan will increase. Could this alienate some groups in Japan and their social capital goes down? What sort of other policies do you think we could do? It's a bit drastic to hold the Olympics. I mean, I'm not saying I'm not against Olympics, but you know, if city after city in the world, it doesn't have to just be cities, want to increase social capital, what are appropriate policies?
Promote for less stress in work environment.
Oh, right. Yes. It's a work-life balance thing. Yeah? You're in the right country to start. Yes? Then we'd all have more time for each other, perhaps. Or even just more time for ourselves, which might be good.
Or for our family.
Yes.
They're part of our social
Mhm.
life.
So, what about restricting working hours then?
It doesn't work much. I mean, it's, for example, 7 or 8 hours that you must work, but there are some people who are working like up to 12 hours
Mhm.
per day.
Hmm.
So it's not only about laws. It should be a promotion for restricting
Mhm.
working hours. In a society, I think in Japan, working is really highly appreciated by community, by society, by norms, rather than laws.
All right, yes. You'd have to, if you want to do something in Japan about work-life balance, you'd have to change the norm.
Or promoting. It's not just the law. The government should do
Yeah.
something about that.
What about more radical policies? I mean, that's fairly radical, but
Pushing people to leave. I don't know.
what about greater sexual or gender equality? Might that improve social capital?
In what sense?
Maybe it would deteriorate it. If you increase gender equality and don't do something about work-life balance, you're just encouraging and giving women the opportunity to become just as hopeless as men in terms of work-life balance. No, I think I was thinking it's a big leap. But you know the idea that the sort of financial crisis that we had a number of years ago and we're still living with, if the boardrooms had been full of women, there's been a suggestion that we might not have got to where we got to, but because it was largely full of middle-aged men, things were worse than they needed to be. Well, is there something similar with gender equality, and maybe it's a good way of building social capital?
I have an interesting example. It's not measured, but it's just a personal observation. I am from Yemen, and this country, as you might know, recently is facing a big disastrous challenge. Before that, the woman's role was not that much important in the business world. She is working as officer, teacher, doctor, but not too much into business. But lately, they started to come up with innovative ideas for business. They created new markets with very simple things, like doing, for example, themes for parties or baking cakes for events. And they started, this community of ladies who are doing business is increasing massively. And so they started to improve their social capital in different ways. So the disaster in this case was predictable them. Nobody suggested, it just happened. And the norm of gender inequality, which is very common in our societies, has not changed as well. But the situation, the economy, pushed them to do that. And so they created new opportunities without changing the norms. So I don't know if gender, yeah, it's important, but I don't know.
Because I mean, well, hardly my expertise, but I'm just thinking greater gender equality might allow women more flexibility in the sort of relationships they build, and more relationships, in which case you get more social capital possibly.
Perhaps.
Well, maybe it's too radical a suggestion. Let's stick to building community halls and... Any other ideas or comments? I find it quite interesting that you're not overflowing with suggestions for how we could build social capital. I mean,
In China, recent years, that we find that some elder or over 40 years old women like dance in the plaza after dinner. I think that is a very good way. That, but sometimes the sounds that noise makes the surrounding that they dislike it. So the media give the pressure on the society or on those groups to. They may when they dance in the plaza, that maybe they will feel guilty or something. That. But I'm not sure whether that if they control the sounds or some other way, that I guess it is a very good way, because many people come out and they dance, they feel very happy and they can do exercise.
Mm-hmm. It sounds such a win-win suggestion for governments, because what's it going to cost them? Nothing. I suppose the only danger is these citizens coming out might speak to each other more, which may not be what governments want. But I get the point, yeah, exercise. I guess you build trust. You have more relationships, more people. So back to our example of one of the mechanisms for improved health, about information and access to services. Oh. Okay, well, I think on that optimistic note, although it's a few minutes to go, let's think of all these citizens in China dancing in the plaza. Oh.
Yeah, just a little question or comment.
Sure.
I'm from the Democratic Republic of Congo, and I know in terms of healthcare, people mostly rely on the community because the health insurance scheme is basically in existence. So I wonder in this context where there is already a sort of existing social capital, because people build on that to access the service. And is it really important to think about building another social capital, or maybe it's important to think of more pressing needs, like how to improve infrastructure, the number of doctors or healthcare personnel. So in this context, social capital it's not really going to add anything.
Okay, I think that's an interesting comment. I think there's two things I would say. One is there might be a distinction between where there's just somehow not enough social capital already, and so any investments we make, we're not getting the full benefit because there just isn't enough social capital to sort of combine with our investments. And situations where we have social capital, it exists and it's adequate level. So there might be that distinction. Yes, if you invest in social capital, it's going to take up resources, and those are resources which could have been paying for more healthcare workers or whatever, or just ensuring that pharmacies have drugs on the shelves and things like that. So it's very hard to argue against that view. I suppose my point as a health economist would be, I think we need to somehow have evidence about how well different things contribute to improving health. I've got an open mind as to whether investing in social capital is a cost-effective method. It may be effective, but but it may be high cost to get that benefit. I don't know. I come back to the not smoking in public places and changing the social norm. I suspect that was highly cost effective. So it may be that there's some investments in social capital that are really good value and many that aren't. But it's going to be very much, yes, I think what you're emphasizing to some extent, and also the comment from Yemen, is we can talk in general terms about these concepts, but the context matters. And any time we start talking about policies, we really have to think about context that you're introducing the policy into. What works in one country may be, what works in one part of one country may be inappropriate elsewhere. Yeah. Okay. Right, well, so we finished now. This is the right time, isn't it? We did start it, yeah. I wouldn't want to... I'm either half an hour late or half an hour early. So we resume for lectures 5 and 6 on Wednesday at the same time in the same room, okay?